So I'd like to thank everybody for joining our Bascom Palmer Cornea Conference here. Today is April 20th, 2020, and we're making use of the coronavirus crisis to try to expand the audience here for our cornea lectures here at Bascom Palmer. So I have the privilege of introducing one of our professors and my mentor, Dr. Karp, who's a professor of ophthalmology here at Bascom Palmer and a specialist in ocular surface cancers. Dr. Karp is obviously well-published, well-experienced in this field, and her lecture is highly anticipated by many in the Latin American audience. But those of you that don't know her personally, she's just a magnificent person and just as kind and accomplished on a personal level as she is academically. So it's been a pleasure to have her and as a mentor and to call her a colleague now. So our lecture is going to proceed in the standard fashion on the Zoom platform here. We have about 50 or so participants live from Bascom Palmer on the call. And we are recording the lecture, which will then be broadcast by Ophthalmo University, our partner here. And I'll turn over the microphone in just a moment to our partners to introduce themselves. Some nuts and bolts about the call. Since we do have a recorded audience, I'll just ask people to make sure that they're muted unless they're speaking, to keep side comments and questions to a minimum. If you do have questions that come up over the course of the call, please ask them in the chat, and we'll make sure to look at that chat and to ask those questions in between slides. We'll try to keep it as interactive as possible because if you have a question to be asked, I'm sure that our broader audience would be interested in hearing the answer as well. So with all of that said, Dr. Andres Benatti is one of our partner ophthalmologists. He's a cornea surgeon out of Argentina. Is that right, Andres?
Yes, sir, from Argentina. Yeah, yes.
And
thank you so much for the introduction. My name is Andres Benatti. Thank you so much, Dr. Karp, for this opportunity, Dr. Tong, and of course, Guillermo Amezcua. He was the responsible of this transmission. We're very happy. We are recording this talk, and in a few minutes after you finish, we will be able to put it on our YouTube channel, and will be open for all Latin America. So thank you so much again for this opportunity, and well, let's enjoy the lecture.
Okay, thank you so much. Rahul, should I stop the video? Is it going to be better if I'm not seeing my face and I just do the slides?
I think most people would love to see your face as you go through the slides. That way we can see all of your multiple expressions, if that's okay with you.
Yeah, that's fine. It's fine.
Yeah.
Okay. So good evening, everyone. And I'm going to speak to you today about one of my favorite topics, which is ocular surface squamous neoplasia. And my title is How to Make These Tumors Magically Disappear. So I have no financial interest to disclose, but the drugs that I'm using are off-label in the United States. And I want to shout out a thanks to my current research fellows, Sarah Wall and Despina Theotoka, and my amazing clinical fellows who are online and teach me so much and help me so much, and my great team of colleagues and researchers, which I see a bunch of people also on here. Satiri, I see you there. It's great. And so thank you all so much. And saludos a todos mis amigos en Centro y Suramérica. It's great to have you here as well. So ocular surface squamous neoplasia is an umbrella term. So it's everything from mild dysplasia to then in situ disease to invasive squamous cell carcinoma. And the risk factors are multiple. Whenever a patient presents, we ask them about the history and the risk factors. We use our clinical acumen to diagnose it. And then we can do a biopsy, which is the gold standard. We can use impression cytology, which is just pulling off the superficial layers of the cell. We can do a pap smear, which is a scraping or a needle aspiration. And now the optical methods of biopsy, which for me, my favorite is high resolution OCT. So in terms of risk factors, the number one risk factor is UVB exposure. And Noah, who you just saw a moment ago, and I fight all the time about sunscreen. He doesn't want to wear it. And unfortunately, the eyes are open all the time, and it's difficult to not have exposure to your ocular surface, to the sun. Xeroderma pigmentosa, I have several of these young kids and now adults in my practice, and it's a terrible disease where they are not able to repair their DNA, and they get multiple skin cancers and other cancers. And this is a typical face disease. They have all the spots, and they've had multiple surgeries on their nose and on their face and on their eyelids because of tumor growth. Here's another patient. HPV is interesting. It's a cofactor in several mucosal diseases, we know, and also plays a role for OSSN and then immunodeficiency. So I'll tell you the story because a lot of fellows are on the line, is that when I was a fellow in 1993, I had only seen one OSSN in Michigan, and all of us piled in to see that one patient because there's not very much sun in Michigan. And so when I got there as a fellow here at Bascom Palmer, I started to see a bunch of them. And I thought, well, maybe because it's sunny and it's Florida that we're seeing it. And at the time I was living with one of my, Don Gass, Dr. Gass's fellow, his name was Tom Cheng. He was my roommate, and we would sit around, and he was working in the path lab too. And he said to me, you know, Carol, there are a lot of, we called it CIN back then, a lot of CINs, like you better look at, like, they're kind of young too, because we learned that OSSN was in 60-year-old males, and this is now young patients. So whenever you see young and cancer, and you say the words young and cancer in the same sentence, what do you think of? Sarah Wall, what do you think of when you say young patient with cancer?
I think of a possible HIV infection.
Yeah. So young cancer, you think, maybe there's a problem going on with their immune system. So at the time, CIN or OSSN of the conjunctiva has a parallel in the body, and that's the uterine cervix. So cervical intraepithelial neoplasia is very, very similar to what goes on on the eye surface. So both occur at a transition zone, both are non-keratinized epithelium, and both putatively also involve HPV. So multiple papers at that time in the early 90s were indicating an increased risk of cervical intraepithelial neoplasia with HIV. And so started to think, well, I wonder if there's a role here in these young patients. And so for my fellows presentation, and back then every fellow had to present, every resident had to present. So 26 years ago, my project was to look at all the young patients under 50 that had OSSN and test them for HIV because they weren't being. And what we found then is I published, this is my first OSSN paper, that I found that in patients that were less than 50 years old, 50% of those patients were HIV positive. And I was the one who was telling them that they were HIV positive. So that was my fellows project. So what we're going to move on to now is basically with OSSN, how to identify it, how do we treat it, how do we follow it. So it is the most common ocular surface malignancy, and it has different appearances. So when the residents say, well, what does it look like? Well, sometimes it's gelatinous, sometimes it's leukoplakic, sometimes it's more papillary, sometimes it's more opalescent. So it can look and in different ways in different patients. The other thing you can look at in terms of thinking of malignancy versus something that's more benign is the borders. So I like to say that cancer is crazy. So here the borders are all irregular. In something like a pterygium, you'll see that the borders are smoother. And then also the blood vessels. In a pterygium, they're more linear. In cancer, it's crazy and squiggly. Then it's not normal to have keratinization on the mucosal surface of the eye. You can get it, for instance, if the eyelids pull down and there's exposure, but you can get it when there's neoplasia going on and rapid turnover. So leukoplakia should make you worry that there's something wrong. So here we see some leukoplakic changes here on the cornea, and this is staining. And there are a couple of stains that we can use. Aditya, what stains are there available to look at mucosal changes on the epithelium?
Oftentimes we will use lissamine green or rose bengal in the clinic, particularly for conjunctival lesions, to highlight them.
Correct. So there's really three. My favorite is rose bengal, which you see here is the pink one, but we don't really have very much. We have to like find these strips and cut them up into little pieces because it's not available now anymore. So we're using lissamine green, and then there's toluene blue. So those are the three stains that help show that there's something abnormal about the mucosal surface. Here's a combination, a patient that has both gelatinous and leukoplakic features. And then this, which is this opalescence on the cornea, this fern-like or small pannus, is definitely something that is more often missed. When you see a big blob on the eye, you know that, gee, that's something wrong. When it's opalescence, sometimes it's diagnosed as a pannus, sometimes it's diagnosed as scars, sometimes it's diagnosed as mapped out fingerprint dystrophy. It all depends on how it looks. But I would say that these corneal lesions are the ones that are often missed. But overall, when there's a mass on the eye, we know that there's something wrong. So I mentioned my favorite toy and the way that I like to diagnose these lesions, and that's the high resolution OCT. And the first time I used this is Jay Wang. He's a biomedical engineer at over at Bascom Palmer, and he developed this high resolution OCT that has 2 microns of resolution, and he was presenting it at a cornea conference just like this in 2009. And what he had developed it for was to look at the tear film and to look at changes in the epithelium that occur with dry eye. And so I was thinking that that's okay, but what would be really cool is if maybe this would work to let me see the tumors. And just as a magical, lucky bug that I am, I got amazing views of the ocular surface. And so after this, which used to be in, basically where Dr. Tonk, your office is, and where Florence, we used to use, that's where my OCT was, his OCT. And we had it, and we brought the patients over basically into your office, and we would scan them in this device. Now we get to use this, which I switched to the ArtiView, which used to be on the 4th floor, and now we have the Avanti, which is now integrated into our computer system, and it's just fantastic because then I can easily look up and everyone can look and see the images of our patients. So here's an example of a patient that has a kind of subtle lesion right here. And now this software with the Avanti and ArtiView here has shows us where our cut is. And then here's the OCT. So Colin, why don't you tell everyone what are the classic features of OSSN on OCT?
Some of the things that we typically look for are thickened, hyperreflective epithelium with a sharp transition zone.
So exactly. So those are three things I say are thickened, number one, hyperreflective, number two, abrupt transition. So here you see normal dark epithelium, somewhere from 50 to 70 microns, and then you see a definite, and this is exactly what you see histopathologically. And then here we can measure that it's 193 microns. Does anyone remember from one of our studies, we looked at what a cutoff is that has very, very high sensitivity for OSSN. Does anybody know that number? Angela?
I don't.
No, just Pina. Anybody read any of our boring papers?
I think 120.
Yes, good. Okay, so Despina Theotoka is a research fellow with me going into ophthalmology, going to Yale. So yes, so what we found is that when we looked at all the OSSNs with a cutoff of 120 microns, so as Dr. Ryburn just said, thickened hyperreflective epithelium, abrupt transition. But if you forgot all that, if you just use a number, if it's over 120 microns, it's most likely something that's abnormal and neoplastic, the epithelium. So we had very high, almost ratio to 100% sensitivity and specificity for OSSN, just based on a cutoff of 120 microns. The other thing is the base. You can sometimes get a sense of whether this is invasive or not. It's not perfect. Here you can see it very well, but sometimes when it's very thick, there's shadowing, and then I can't really tell where the base is. But this, you can see, is a non-invasive. This is a surface neoplasia only. Okay, so what are our treatment options? So the gold standard for what the majority—
Dr. Karp, if I can have you back up one slide, for those in the audience that are not as accustomed to look at OCT for tumors and so forth, can you go through some of the landmarks on this OCT as well and just point out some of the differences, the tear film, the epithelium, the basement membrane, corneal stroma, limbus, sclera conjunctiva, and so forth, just so the audience is very clear about what you've defined here?
Sure, thank you. Okay, so this is a high resolution. It's about 5 to 7 microns view, and it's a cross section. So you see it's right here. And what we see right here is, here's the cornea. Here is a shadow image of the iris. And so here is the limbus and here's the sclera. And what you see here on the cornea, the first thing you're going to see is a very hyper-reflective line, which is the tear film. And then you see the epithelium, which in normal epithelium is dark and thin, of 50 to 70 microns. And then you can see Bowman's layer. And then you see the corneal stroma, and you can see decimase and endothelium. So for me, I'm focusing now on the surface and the epithelium here. Then this is what we talked about, what Dr. Ryburn said, an abrupt transition, thickened hyperreflective epithelium. And then here is, this is the sclera and the conjunctival epithelium. We don't see it too well here, but the conjunctival epithelium is often a little bit hyperreflective and stringy under the stroma is hyperreflective underneath the thin epithelium. Thin in a normal eye, here it's thickened because it's an OSSN. You see it's all the way over here. And then in another lecture, some other time, we can talk about like what pinguecula and what pterygium and so forth, and what lymphoma and melanomas look like on OCT. This is all thickened epithelium of OSSN. So then we're going to move on to what do we do? Like I was saying, most of the world outside of Bascom Palmer has traditionally just taken these lesions off. I've been a big fan of treating these medically. Main drugs are mitomycin, 5-FU, and interferon. I have used other things. I've used retinoic acid and anti-VEGF, and I've used cidofovir, and I've even tried
Is that me or we lost Dr. Karp?
I think we lost her.
We lost Dr. Karp.
I think
Yeah.
she's
I was
She's still in the
monitoring.
meeting.
I think we just, I think she,
I'm back.
there you
I'm back.
Hey.
Okay. Now do you hear me?
Yes.
Yes, yeah,
we do.
we've got you.
All right, I'm back. I wasn't lost, really. I was still here. Where'd she go? Okay. So as I was saying, that this tumor occurs at the limbus because that's where
We don't have your screen, or at least I don't have the screen. If you could share that once more.
Oh, all right. Noe. Te necesito. Noah, por favor. Noah, I need you to share the screen, please.
So if you go on the bottom, there's just like a share screen. It's gonna pop out if you just.
I know. It's just I need to share again. Wait. There we go.
We don't all have a Noah.
Yeah, I know. Okay. And then start the video. Okay. There we go. There's my man.
Thank you, Noah. Thank you. All right, we're back.
All right,
the good part is that on the recording, we can cut that right out. So there you go.
Okay. All right. So let's see here. All right. So what we see here are some typical features of neoplasia of the conjunctiva and the cornea, where it's gelatinous and papillary. There's some feeder vessels that look kind of crazy. It's straddling the limbus. And here you see the opalescence on the cornea. The high-res OCT is classic as well, so that looked like an OSSN, but we can confirm it with the OCT where we see this thickened hyperreflective epithelium. You can't really see the abrupt transition, it's more over here on this scan. You can see that this is thickened abnormal tumor. So this is OSSN based on our clinical judgment and by OCT. So let's say we're going to take it to the OR. Here it is, looks kind of like a little kidney. This is the tumor. So if we're going to take it off, I need margins, right? I need 4 millimeter margins. So that means I'm going to have to do this, which means I'm going to kill, maybe 180 degrees of my stem cells, and then Dr. Tonk or a Mesqua or Martinez are going to then need to do a slit on this patient. So my decision was to treat this patient topically, which I love to do. And my potion was 5-FU. So I take 5-FU, I mix it, not me, but our pharmacy makes it to 1%. I use it 4 times a day for 1 week, and then I give a holiday of 3 weeks off, and then repeat. And I see them after 2 cycles, and a total is usually 4 cycles. So this is what my patient looked like after 4 1-week cycles of 5-FU. And this is how it just magically goes away. Now, surgery has a lot of advantages. It's diagnostic and therapeutic, it's quick, it's over in a day. Medicine takes longer. But the downsides are stem cell deficiency, sometimes ugly scars, and more than anything is that you can't guarantee that you're going to get out all the tumor. A drop goes all over the surface and treats the whole conjunctiva and corneal epithelium, whereas your surgery, you're only taking out what you're taking out. Here's how I do it. I use 4 millimeter margins. I mark them. We do a no touch. No touch means that you're doing the borders first. Of course, you have to eventually get under where the tumor is and you touch it as you take it off. This is very important to orient it. This is a cardboard. I don't like anything that's waxy, like filter paper, actually. I like the card that you turn and dance with. And I label it superior, inferior, temporal, and this needs to be relabeled in pencil before it goes into formalin. I use alcohol, absolute, for 1 minute, and then I scrape off the epithelium, but I do not violate Bowman's. I don't do a keratectomy. That was common a while ago, that we would actually take off part of the cornea and take off Bowman's layer, but that's not a good idea. Bowman's is your friend. Then I cryo the conjunctiva and the limbus in a double freeze with a slow thaw. And I close with AMT. And I always ask, anyone who's new and watching the surgery, I say, oh, how what part of the cryotherapy kills the tumor cells? So Angela, what are you going to tell all our students there? Is Angela still there? Aditya?
It's during the thawing phase after the cryotherapy.
Yeah, exactly. So it's important to do a slow thaw. You might feel like, oh, I got to rush through this, but you need to wait till it slowly thaws. That's what breaks down the cell membranes. I like a dry surface, so BSS, I don't want possibly to seed any abnormal cells. And the usual result is very pretty, that patients look good. But extensive surgery can cause some blepharon, scarring, and stem cell deficiency. So the reason why I like, as I already said, medical therapy is that it treats the entire ocular surface, and it's especially helpful in recurrent disease, annular disease, a lot of limbus involved. And if nothing else, you should try chemoreduction before doing surgery. The downside is that it takes longer than a one-day surgery, but I think that the advantages outweigh the downsides. And there are costs to the patient out of pocket. They have to be compliant. So mitomycin is something we use a lot in ophthalmology. For this tumor, I use 0.04%. I use it 4 times a day for 1 week. And then I think the important thing about mitomycin, which I really don't like very much, I call it my diablo, is that you need to wait until the eye is white and quiet before you recycle your mito. And I do put in a plug. I do have them hold it here so that it doesn't cause punctal stenosis and irritate their nose. But the most important thing is waiting until the epithelium is intact before you recycle. And it does work. It's just very toxic. In the States, it's not inexpensive. It's $400 per bottle. But I think in South America, it's a lot less expensive. Papi, ¿me haces el favor de cerrar la puerta, por favor? Papi, papi.
And Dr. Karp, this might be a good time to take a couple audience questions. The first thing, you had a case that you presented up front where you used the 5-FU to achieve a medical cure. And we had a question about why not interferon. So I imagine that you're going to get to your roundup of when to use which in a moment. The other question was pertaining to the margins. So you mentioned cons of surgery are taking wide margins, and you said something about 4 millimeter margins. The question says, I thought that 4 millimeter margins were used for melanoma and 2.5 millimeters for OSSN.
So the 4 millimeter is correct for melanoma, and for OSSN, I still try to do 4 if I can. There is not great data on what is going to be, with every tumor, it's going to be different. And at the very end, I'm going to talk about that too. But depends on the location. If you can take 4, I try to take 4. And if it's in a location where you can't, then I take a minimum of 2. All right, so let's go through this, and I will talk about which ones to pick and how. So this is a patient who had a diffuse tumor, which you can see all over the limbus and the conjunctival surface, which would be very, very difficult to cure with surgery. And this is what he looked like after 3 cycles of 1 week cycles of mitomycin, with just dramatic resolution of his tumor. If you're very astute here, you're going to see that there's still a little leukoplakia here that needs a little more treatment. And here's another nodular lesion that is treated with mitomycin. The eye looks really red because that's what mitomycin does. It turns it into like Diablo, and then it quiets down, and often we'll end up seeing, which we may not have seen well, a pterygium or pinguecula underneath, because that is an actinic related disease. And so the eye is not happy on mitomycin, and patients have given it all sorts of names. I call it La Gota del Diablo, but people have called it Saddam Hussein, and it's not comfortable. And I do think that mito itself causes limbal stem cell deficiency. So the eye is on fire. And I do use steroid. I allow them to use steroid as they need to calm el fuego. So 5-FU is now my favorite way of treating this disease. And the main reason is because of the cost and because it's much less toxic than the mitomycin. I use this, as I said, 4 times a day for 1 week on, 3 weeks off, 1 week on, 3 weeks off, for a general 4 cycles.
Yeah.
And we looked at this as a primary treatment and looked at our patients, and then Dr. Venkateswaran, one of our residents, and we looked at this comparing interferon, and it had similar efficacy to my successes with interferon. It's also very, very inexpensive. So for $50, you can treat the tumor and get it to miraculously go away. So here's a gelatinous lesion that is treated with nice resolution with topical 1-week cycles. And here's a patient from the resident clinic who was Haitian, and she had this very big tumor. You can see it's actually a pigmented OSSN. So remember that mostly it's non-pigmented, but OSSN can have pigment in pigmented individuals. So we were actually planning on excising this, but she didn't have any insurance and she needs to get a PHT card. So I said, all right, well, let's just put her on 5-FU until she gets her paperwork done. And this is what happened after just 2 cycles of 5-FU. So interestingly, you see she had pigment here. Now you can see the pigment or racial melanosis, and this tumor went away. It was very, very dramatic. I would still, and you'll see, we'll talk about it at the end, even if you say, oh, wow, it looks like it's gone, I still always treat for 4 cycles. And whenever I think it's gone, I still do another 2 cycles, but I have the OCT. So we tell the world, if you don't have an OCT, then do another 2. It is and can be epithelial toxic and cause a KED, but most of the time patients are very comfortable. And I just call it my diablito because it can be a little uncomfortable. It's mostly to the lid, and I have them put Vaseline on the skin so that the lid doesn't get excoriated. So interferon, someone was asking. This was my favorite way of treating OSSN. I'll tell you my story in a second, but these are low molecular weight glycoproteins produced by our own white cells. They have both anti-neoplastic and antiviral properties. And it's used in other parts of the body for other diseases, which are neoplastic as well as viral based, like condyloma. So my story, many of you know, but I'll tell it again now if you don't, is that when I started in '94 on the faculty, there was not too many people who wanted to see La Doctora Karp. So at the time, Sharing Plow was doing a study trying to get interferon alpha-2b approved for hepatitis B and C. And they just needed someone to look at their eyes. So Dr. Norton and Dr. Clarkson asked me if I would just see all the Sharing Plow patients that were in the liver department at UM so that we would get some nice money for that. And then I started thinking about interferon and learning that it was antiviral and anti-neoplastic. And at the time, remember I told you that my fellow project was, there was an increase in HIV and cervical intraepithelial neoplasia. It was actually an AIDS defining lesion at the time. And they also started injecting interferon into the cervix for cervical intraepithelial neoplasia. Steve Maskin, one of our fellows, had just tried this with eye drops for 1 patient. And I wondered if maybe this would work on the eye surface. And so I was just standing around the pod talking with Dr. Forster, and I said, you know, maybe it's going to work for this OSSN. Like, and he said to me, no, you should really put this together and present it at cornea conference when I was a fellow, and then just, you know, see what you think. I'm sorry, not a fellow, my first year. And so what I did was I made up a protocol which was exactly the same as what they did for hepatitis. So I said, we're going to inject 3 million international units and half a cc. We're going to do it 3 times a week, just like what the hepatitis patients do. We're going to do it subconjunctivally. P.S. It's never been done before. It's never been injected on the eye. And we're going to use the eye drops. And I wrote it up, and the IRB said, sure, which Would never happen now if it never been tried and injecting some new drug. So I don't think I would have been allowed to have done it, but in 1994-ish, they let me do it. And the results was magic. It worked really, really well. So that 1 million is exactly what I still do. I did look at 3 million and compare, but 1 million worked just as well and is less expensive. And the injections are 3 million, which is the same that I tried way back then, which is what they do for hepatitis. I do it in half a cc and I inject it in the conjunctiva right near the tumor, right into the tumor. I don't do it 3 times a week like my original studies say. I do it once a week when I'm treating them infections. And Carol Shields, my friend, colleague, my big Carol, I do it once a week, 3 million. She does 10 million once a month. I've also tried pegylated, which worked, but it's really expensive. So here's an example of a patient with a big leukoplakic and a gelatinous lesion. Oopsie, wrong one. And here's the patient after 4 times a day. Now, interferon is different in that interferon is very gentle, but it's an everyday drop. So it's not cycled like Mito and the 5-FU. You need to use it every day. And all the drops are refrigerated. And it had a really beautiful result. Here's another patient that we saw recently, and he had this opalescent. And remember, when they're on the cornea like this, it's coming from the limbus. And doing surgery, you have to kind of guess because he had no limbal lesion. If you're going to take him to surgery, you're going to say, I'm killing all these limbal cells. I got to take them, and I think, but I don't know how far, but I got to kill the limbal stem cells because that's where it's coming from. So topical therapy is really good when it's a corneal lesion. And so this is what he looked like. He opted for the interferon because he's a police and he didn't want to have a red eye. And this is what finally worked for him. So injecting when it's on the cornea, you can still inject. I injected the limbus and the cornea clears. When it's on the conjunctiva, I inject right next to where the tumor is. It goes right into the tumor. So complications, well, interferon is my angel drop. It's very well tolerated. It's gentle. So I would prefer having interferon on my eye because it's not toxic at all. It's an immune modulator, not a chemo. The injections do cause a flu-like syndrome because they revs up your immune system. The problem with my interferon now is that it's crazy expensive in the United States. When I started, it was about $100 a month. Now, our pharmacy charges $800 a month. And not only that, it's hard to get. So that's really why I don't use interferon that often. It's just, I'm just very cost conscious and it's crazy expensive. So Mitomycin, but then Ralph Eagle stands up in my meetings and he says, $800 a month, that's nothing. Do you know how much Humira costs or whatever? So it's all perspective, but I can get the job done with $50 and it works really well. So here's Mito. It's QID for a week. Excuse me 1 second. Papi, por favor. Sorry. And I put in a punto plug and I call that my gota del diablo. Interferon eye drops are my angel drop. It's 4 times a day, every day. And the injections I do weekly now of 3 million. And it depends. I just do it until it goes away, +1. The main problem I have with interferon is just the cost, which is $800 a month in the US. My friends in India, it's $1. And so it's a great option if you're in another part of the world that has inexpensive interferon. And 5-FU, which I use the most of right now, is incredibly affordable. It's my Diablito, and it's $50. So remember the number 4, minimum 4 cycles of 5-FU, minimum 4 months of interferon. Usually mitomycin is 3 to 4 cycles as well. All the drops have to be compounded and we refrigerate them all. Can you combine? Yes. So we looked at this. You can either chemo reduce and then do surgery. If it plateaus, you can, I'll show you in a second, if you do surgery and you have positive margins, we can use medication as well. So this is a study that we did back in 2012, Dr. Galora and I, and what we looked at was patients that, let's say you do the surgery and you end up with a positive margin. Well, then either you have to go back and take out more tissue, or you can use topical chemo. And at the time I was using interferon. So 2 months of interferon with a positive margin decreased the chance of recurrence to that equivalent to having a negative margin. So when do you use the medicine and when do you use the sword? A little bit, that was a question that was asked. How do I decide? So if I have a very large lesion, multifocal, where surgery is going to kill a lot of stem cells and I'm going to cause a lot of scarring on the ocular surface, I prefer to use medication. Some people say to me, "Oh, it's too big. I don't want to use medicines." So my friend, colleague, Soteria Palura, when I was giving this talk, she says, "Oh, the people in Greece, they think you can't use it when it's a big tumor." But that's exactly the perfect time to start and try, because most of the time it's going to work. If there's a doubt about the diagnosis, you get an OCT and it's just not classic for OSSN, you need to take it off, because amelanotic melanoma is always a possibility. So if you have a doubt, then you take it off. If the patient's not going to use their medications, their drops, or you decide that they won't tolerate an injection, then also medicine's not going to work and you need to take it off. Okay, so how do I decide about which medicine? So if money is not an issue at all and they want a white, quiet eye, then interferon, if they're compliant, is perfect. But most people have trouble affording $800 a month for a minimum of 4 months. So 5FU, which is $50, is going to be my choice. And mitomycin is my last choice for OSSN because of its toxicity, and you can just get the job done and in a gentler way. So now just a little bit more magic looking glass. This helps me not only to diagnose, but also to follow. So
one, I'm sorry, before you go on OCD to follow, we did have a question on recurrence rate following mitomycin then with interferon. Are you aware of data showing a differential recurrence rate amongst the, or a different response rate, I should say, amongst the options, the medical options you've identified?
So I would say they haven't been compared head to head. There hasn't been a randomized, masked study, which is something we should do because that doesn't exist. It's like looking at this study and their recurrence rates and this study, and then they use it in one way and we use it in a different way. But I would say overall, all the drugs have very similar efficacy. And I would say overall, there's an 85 to 90+% chance that whichever drug you use is going to work. And in terms of recurrence rates, I also think, in my experience, they're all very similar. I think the main reason why we have recurrences is that you have not completely eradicated the disease, which this next slide is going to show. So I think that leaving residual tumor is the main reason why we do get recurrences. And we just published a study looking at what % of patients have subclinical disease. So Ann Tran, who was a resident, was the first author on this paper, where we basically, I looked at, whenever I said the tumor's gone, then we looked at the OCT and it was like, uh-oh, there's actually a little bit of tumor left. We can see the thickening. So let me just show you here. Here's a patient who has this little gelatinous spot, decided to do, and we do the OCT and we see this thickened hyperreflective epithelium. And so this is OSSN, and he decided he was going to treat it medically. And so this is what he looked like after 2 months of interferon. So this actually looked very good. But when you do the OCT, you see that there is residual thickening and hyperreflectivity. So it looks like it's gone, but there's still tumor there. So remember, I said 4 months anyway. So here's 4 months. And to me, this actually looks like the same. I mean, maybe I mean, I think I'd kind of be making it up to say that clinically it looks almost the same, but now you see that the epithelium is really normalized. So I think what we found in this study was that the one that Antran did is that 17% of patients have residual thickening, residual disease. When you think clinically, it's gone. And I think one of the problems with treating is that you can't just stop as soon as you think that clinically it looks fine. If you have an OCT and you scan it and it looks beautiful and thin, okay, then you're done. But if you don't have an OCT that scans the entire surface, then what we found is that it took 2 more months of cycle, 2 more cycles, say 5FU, or it took 6 more weeks of interferon until the epithelium totally normalized. And then in those patients that were treated, their recurrence rate was 0. So it's important to also scan the entire surface. So for instance, Jaime Martinez, who's our fellow and now joining the faculty, he's a whiz at this, and he knows, because he's a clinician and good at scanning, and he scans the entire surface and anything that looks suspicious. And our techs are very good at it, but they will scan what we tell them. And so you have to draw them a picture, and if you don't put where you exactly want, or if they don't do enough cuts, you may miss something. I'm hoping that in the future, and we need some good biomedical engineers, is that it's not going to be where we say. We'll be able to scan automatically the entire ocular surface, just like, you know, an MRI, or I mean, that's still with cuts, but we're going to be able to scan and FOSS the whole surface, and that will hopefully eliminate the problem of inadvertently missing an area.
We have a couple questions from the audience, if now is a good time. The first one, I guess, gets at a couple of questions, and it says, for the recurrences after surgery, how many cycles of 5FU do you do? So if you could break that down for us and actually talk about, again, how many cycles do you do on a treatment naive patient in general as a starting point? And then what this question is getting at is, let's say the patient that's treated with excision and cryo as an attempt at a definitive cure, who then recurs, do you then change that protocol, speaking specifically to 5FU?
Yeah, so with 5FU or naive for a primary treatment, it's always 4 at a minimum. I never stop at 2, even if I think like that lady with the Haitian lady with that big tumor that looked great, I always do 4. So, however, sometimes we have to do more until the OCT is completely normalized and the tumor is gone. But it's usually 4 to 6 cycles to get rid of your tumor. You can pretty much bank on it. Some patients need more. Sometimes a tumor will plateau and then you have to confuse it and switch medicine. So that sometimes happens that we haven't talked about. But most of the time I can cure the tumor with just 1 drug. Now, if I've excised it and I've cryoed it and I have positive margins, I always go and I look with my pathologist, with Dr. Dubovi, and I look at the tissue margin. And I want to see, like, what kind of residual disease is there. If it's really big, nasty disease, then I may go back and take more. However, if it's big, nasty disease, I probably would have seen it. Usually it's a small amount of microscopic disease and I cryoed. So in that scenario, I will generally do 2 cycles of 5FU. And that in our studies, although that's what in the original study that I showed you in 2012, that was with interferon, and that was 2 months of interferon. And in general, I will do 2 cycles, which is 2 months of 5FU if there's residual positive margins.
How often do you see recurrences following what you feel is a total surgical cure, meaning you think you got it all, you got negative margins, and then you follow them in the clinic and lo and behold, something's new on OCT or on biopsy. How often do you see that for those in the audience that are still treating these primarily surgically, I think, or had been in the past treated surgically and are now following patients? I think they might be interested to know.
So let's just say the literature. What's the chance of recurrence if you have negative margins? And what's the chance of recurrence if you have positive surgical margins? So the best study that this was done by Jeff Tabin, you know, the guy who climbed Mount Everest, who's in the Himalayan Cataract Project. So he did a study where he looked at the recurrence rates. And so the chance of recurrence, if you have positive margins with your excision, is really high. It's about 50% that you're gonna have local recurrence. So that's too high, and that's why we have to do something about it. Either reoperate or use a chemo or immunomodulatory therapy. But even with a negative margin, the chance of recurrences can be even up to 30% with negative margin. And why? Well, I think that it's two things. I think that there are crazy cells sometimes that are been affected by the sun. Just like if you have one skin cancer, you may get another one like kind of nearby. You could still get another new primary. Not the same, not really a recurrent tumor, but not necessarily the same recurrence. So I think that happens. And that's why I think that using a medicine on the surface of the eye is helpful, because it may kill those little weeds or cells that are there that may think about going crazy. But I would say, you know, overall, if you have an excision, in my hands, if you do an excision with extensive cryo to the cornea and the conjunctiva, I think that the chance of recurrence is between 5 and 10%. But in the literature, it can be as high as 30. And I think that's because there are crazy cells and people have had actinic exposure that a new primary can pop up.
And then the last question before you proceed has to do with what is your follow-up on these patients after the lesion has resolved? Yeah. What's your follow-up?
So the follow-up regimen is once their OCT is completely normalized, they get to stop their medicines. I see them every 4 months in the first year, and then I see them 6 months in the second year, and then they get yearly. So I see them every 4 months. Okay, so here, this is hot off the press. This is my Aos thesis. So there's this society that I guess is the oldest society in I think it's the oldest medical society, but it's the American Ophthalmological Society, and you have to write a thesis. And my thesis was to see if I could use OCT to map the margins, and I call this Optical Mohs. And so what we did here is that we used the bioptogen, and this is with another biomedical engineer, Marco Ruggieri. And this is a different device where here's the tumor. And here it looks like it's kind of gelatinous and a little bit abnormal, but I'm not sure how far do I need to go. And so here's the OCT, and it shows that the part next to this big white thing is also hyperepithelium. And here you see it stained with rose bengal. So I picked a landmark, and here's the landmark, and we did an NFOS OCT, and I marked where it was normal. So here's my landmark where the star is, which is this little squiggle. And then I looked by OCT where it was normal, and that's where my X was. And then I marked that with ink. And then this is the OCT predicted margin. Then I went my 4 millimeter and took a wide excision. And here you see the pathology. So as we talked about, there's an abrupt transition from normal to abnormal when you have OSSN. And this is the most beautiful normal to abnormal. You can't get prettier than that where that asterisk is. So, and you see where the arrows are, that's where my ink was marked as the OCT predicted margin. So this was really helpful that I was able to find the margin of my tumor. And if we could do this when it's integrated, we do have OCT integrated into our microscopes right now, but it's meant to show us depth inside the anterior chamber, to help us with our DULC, or to help us with our DSEC and our DMAC, but it doesn't give details at all for the epithelium, or I've tried it to look at the tumor. It is just no good. So we have to wait till something can be integrated into our microscope that's high resolution, that we could then map out the eye and then say, oh, here's the edge of the tumor, and we could much better then be sure that we're going to be taking it out. So this is hopefully going to be something in the future. So just to finish, I just want to say that I am very blessed that my career has been because people have given me good ideas. Remember, my roommate at dinner, Tom Chang, gave me the idea of looking at HIV and OSSN. And then Dr. Forster pushed me, encouraged me to do interferon study looking at that. And then Jay Wang had this device that he let me play with that turned out to be beautiful for ocular surface tumors. So this is me as a fellow, which I say was, you know, looking good in the 90s. And then this is me now. And I think you guys can probably attest that this is my same chair and my office, and this is what I look like now. So in summary then, surgery works, but large surgeries can cause complications, mostly stem cell deficiency that we worry about. And then mitomycin, 5-FU, and interferon are great potions. And I'm very excited about OCT because I think we can expand the roles, not only to tell us what it is, but tell us when it's gone, hopefully, and FOSS where we won't accidentally miss an area, and then bring that into the operating room where we'll be able to do excisions to with confidence as an optical Mohs. Thank you so much.
Thank you very much, Dr. Karp, for that excellent talk. We have a couple of questions. Most of the questions we got to as we went along. We have a couple of questions remaining. And for those in the audience that wish to raise any additional questions, please go ahead and submit them in the chat. If there's anyone in the audience that wants to participate, has any comments, or has anything additional to offer, please go ahead and unmute yourself and your video, and we'd love to hear from you as well. The questions we have a couple. One of them was piggybacking on the what you said about the relatively high rate of recurrence after primary surgery excision alone. And so the question was, why not treat all of them with adjuvant topical chemotherapy?
In addition, you mean, or with adjuvant?
In addition, yeah, and adjuvant in the sense that
you do surgery
even
plus.
if surgery plus, even if you've got negative margins, let's say, even if you think you got it all.
So the study that I showed you that was done with Mike Zegans, this one. So this one is exactly that idea. Like, why not do surgery? Well, this was surgery versus, but also looked at both. And in that study, looking at all the literature, we did find that surgery plus some adjuvant was the lowest chance of recurrence. So do you say, so should I treat every patient that I excise also with a little bit of topical chemo? I would say, you know, probably that would be the absolute, that is the lowest. That is what we found. When I have negative margins, I do not always treat them with adjuvant if everything's clear. But I'll say that the results of our study showed that it is probably a good idea to do both, in particular in a high-risk patient or a patient that has had recurrences and I'm excising. I definitely will use adjuvant. And someone who's had a lot of skin cancers, I definitely will use adjuvant for 2 months afterwards. And I wait until they heal, which is another thing. Wait until their eyes completely quiet, because if you put on 5FU or even interferon, they may feel like uncomfortable and want to keep using it. So I would say it hasn't been looked at in terms of a prospective study, if that's really better, but in our retrospective analysis, they did do better if they had both.
Okay, great. I'm going to unmute Dr. Daniela Tassa, who wants to offer her experience and a question. Okay, Dr. Tassa, you can go ahead.
Hi, Dr. Carl. Have you ever tried Mitomycin, but with half of this dose, like 0.02%? We used to use it, and it's toxic, but we have great results with it. We do the occlusion of the lacrimal point, and we used to take also Hyabac and doxycycline. I don't know if what's the name in here?
Doxycycline, yeah.
Yes, to try to
calm the inflammation,
to damage a lot the surface, and stopped for 10 days. If it's okay, we continued for 3 times, and it's very cheap, and I can see a bigger difference with the other options. What do you think about it?
Yeah, so I put on my slide 0.02 to 0.04. So I usually start with 0.04 and I use it for only 1 week. But if they're toxic and they can't tolerate that, then I will do the 0.02 and the half strength. And there's even been published, but I have not used, in 0.002, using it every day. But I usually start with a 0.04, but the 0.02, and my colleagues in Israel, Kobe Pear, they like 0.03. So I think anywhere 0.02 to 0.04 will work. I usually hit it harder because I tend to use the Mito in the ones that aren't responding to my other therapies. And so I want like the strongest possible dose. And most of the time they tolerate that fine. I mean, fine for mitomycin, but if not, I'll lower the dose, and 0.02 definitely will work. It's just a little slower.
Okay, thank you very much. And I missed the beginning. I don't know if you already said, but you used Bengal rose to mark. We used to use toluidine blue, and is there any difference in your opinion?
So we did mention that early on. In the States, we have rose Bengal and we have lissamine green. I mentioned that the toluidine blue, but we don't actually use that in the States, but I've seen it with my colleagues in South America. So my favorite is rose Bengal, but now rose Bengal is difficult to obtain in the States. So now I use more lissamine. But I think they all work well. They stain devitalized cells. So fluorescein is denuded cells, and the other stains are devitalized, something that's abnormal about the surface. So it will stain with tumor, but it will stain with dry eye. And so it will stain with other surface problems, but they're all 3 of them are helpful.
Okay, thank you very much.
Thank you.
Our next question comes via the chat, and the question comes from Kumar Sambhav in UF Jacksonville. How common are recurrences, and what is your usual mode of therapy in these cases? I think it would be great also if you could piggyback on that and also talk about treatment failures and when you might jump ship on one modality and go to another.
Okay. I just remembered yours. I forgot what Kumar's.
How common are recurrences, and what is your usual mode of therapy in these cases?
Okay. So let's say if it's surgical, we talked about recurrence rates vary from 5% to 33%. And my preference is that if it's a surgery, then if they have a recurrence, I treat them medically because I suspect that there was residual disease, there was microscopic disease. And so my preference is when I'm dealing with a recurrence is that I'll treat them with a medical therapy. Then which medical therapy? That is the same algorithm. Do they have money? They can use it every day. Is that too inconvenient? If they're going to cycle it, can they afford? If they I usually will try 5-FU over mitomycin because it usually works and it's just so much cheaper for us in South America and less toxic. In South America, mito is also cheap, but it's just so much more toxic than 5-FU. 5-FU is so gentle. In terms of Dr. Tong's question, what do I do? And so I'll treat a patient, let's say I pick an agent of interferon. I'll treat them for 2 months and I want to see them back. If I'm treating them with mito, I want to do 2 cycles or 5-FU 2 cycles. And I should see a change in 2 months. And if I don't see a change, then I need to change my game. Either I have to think that, did I misdiagnose this? And I need to do a biopsy and see if it's the right lesion or I'm treating the right disease or I got to take it off. Or I did, and I'm sure that I did a biopsy, it's OSSN, but it's not responding. After 2 cycles, if I see a little, maybe I'll try 4 cycles, but if I see no change, I usually will switch to another drug. Or it is responding, and then this last little bit is really stubborn, then I'll switch drugs because I think that tumors do get resistant to a chemo or immunotherapy, and switching it up will almost always then just get rid of it.
Okay, well, thank you very much. It looks like we've finished just about all of the questions from the audience. So Dr. Karp, I want to thank you again for giving this stellar lecture. You got a lot of positive feedback on that from the audience. Thank you to those of you who came in via the Zoom, and of course this video recording will be uploaded to Ophthalmo University as well, where hundreds of other ophthalmologists may have access to it. So I think that that's a great silver lining to this crisis, as we've really learned to leverage a shared knowledge and shared academic effort here in getting these things shared across the world. So that's stellar. I did paste the link to Ophthalmo University down in the chat for those of you who want to find that and keep track of that lecture. I want to congratulate them for pulling this this broadcast off. They seem to be doing this concurrently with an entire other lecture, Mastering Cataract Surgery, where Ike Ahmed and Shinyamani, amongst others, are giving a live talk as well. So somehow they managed to do both at once. So kudos to them. I don't know if any of them are still on the call, and if they want to have any closing comments. If not, then
Raul, I'm here. Andres, I want to say thank you again for this opportunity. Thank you, Dr. Karp. It was an amazing lecture, as usual with your lectures. So thank you so much. We will have this lecture very soon on YouTube, on our YouTube channel, so you can enjoy it there. Thank you so much, and hope we can repeat this many, many times.
Thank you. I want to thank my fellows, my research fellows, my colleagues, Bascom, Palmer, and all my amiguitos in America. So thank you so much. It's my pleasure.